I forgot to record. Let me just go to a whiteboard and then we're going to talk about it. Okay. Okay, so what are the characteristics of a junctional beat or a beat that originates from the AV node? The characteristics of beats that originate from the AV node are the following. One, an inverted P wave before the QRS complex. Two, an inverted P wave after the QRS complex, or no P wave whatsoever. Okay, so those are the three conditions or characteristics of beats that come from the AV node. One of the three, an inverted P wave before the QRS, inverted P wave after the QRS, or no QRS whatsoever. That is how we arrive at the fact that this is a junctional beat. Okay, so the second thing that I would like to ask you now is, notice the QRS complex. Is the QRS complex normal? Is the QRS complex normal? No. Okay. What is the problem with the QRS complex? There is a notch, or it's a wide QRS complex. We all know that a normal QRS complex should be less than 0.12 seconds. And anytime that there is a widened QRS complex, this is a manifestation that there has been a problem in the conduction of electrical impulses in the ventricles. And therefore, it causes a wide QRS complex. So one of the reasons why there might be a wide QRS complex would be that it is an impulse that originates from the ventricles. Or it could be as a result of what we call a bundle branch block. All right, inasmuch as this is a regular rhythm, we notice that this probably is a bundle branch block. And the way in which we therefore identify whether or not the block is going to be in the right bundle or in the left bundle is always to look at lead V1. So remember now, anytime that you have a wide QRS complex, you must always look at lead V1. And when looking at lead V1, this is going to be your clue as to whether or not it is a right bundle or a left bundle. If the QRS in V1 is negative, such as in this case, negative means to say that it is negatively deflected. It is left bundle branch block. Let me repeat that. The way in which you can identify which bundle is blocked is to always look at lead V1. Actually, you can look at lead V1 and V6, but for simplification, I would like for you to just look at lead V1. If lead V1 is negatively deflected, what is negative deflection? The waveforms are coming down from the baseline, such as in this case, this is what is known as a left bundle branch block. Are there any questions pertaining to that? Okay, so let's move on then. Here is another ECG. What do you notice about the QRS complex? What do you notice about the QRS complex? They're wide. Okay. So this is another situation where we have a bundle branch block. So my question to you is, what lead are you going to look at again? You're going to look at lead V1. And when we look at lead V1, what do we see? We see that lead V1 is positively deflected. So if you look at V1 and the complex is going upright, then this is a manifestation of a right bundle branch block. So during a right bundle branch block, the right ventricle is not directly activated by the impulses traveling through the right bundle branch. The left ventricle, however, is still going to have a normal activation by the left bundle branch. And these impulses are then able to travel through the myocardium of the left ventricle to the right ventricle and depolarize the right ventricle this way. And this causes, therefore, a widened QRS complex. Is that clear to everyone? Okay, so in summary, whenever we are looking at a widened QRS complex, we must always make it a habit to look at lead V1. You could look at V6 as well, but as I said, we're only going to use V1 for simplification purposes. So if there is a upright portion of the QRS complex in V1, then that means to say that this is a right bundle branch block. If the complexes are mostly negative in V1, then it is a left bundle branch block. Is that clear? Are there any questions so far? Okay, let's move on. All right, what is your diagnosis? Okay, so once again, we have a block, right? How do we know that we have a block? Well, we know that we have a block because there are P waves without a QRS complex. So whenever you have P waves without QRS complex, what do we have? We have a block. Correct. So whenever you have a block, the next thing that you have to do is to make sure that you measure the PR intervals. So we're going to measure the PR intervals, and I'd like for you to look at the behavior of the PR intervals. This is the first PR interval. This is the second PR interval. And if we move it, we move the ECG, we're going to find out that the PR intervals remain the same. So whenever you have an AV block and you are measuring the PR intervals, what's going to be important is that whenever the PR intervals are going to be the same, then that means to say that the block is going to be a second-degree AV block type 2. Type 2. If the PR intervals are variable, then this is going to be a third-degree AV block. And if it is going to be prolonging, then this is going to be a second-degree AV block type 1 or Mobitz 1. Okay, so the answer to this is that this is a second-degree AV block type 2. And the reason for this is because of the fact that the PR intervals are the same. So what is the implication of this? The conduction delay in this type of AV block occurs below the AV node within the His-Purkinje system. So about 70% of the time, the block occurs below the bundle of His, which is going to produce a wide QRS complex. Now, in around 30% of the time, such as what happened over here, the block occurs in the bundle of His, which is associated with, therefore, a narrow QRS complex. So what is the implication of a second-degree AV block type 2? This is a dangerous rhythm. And therefore, whenever we identify this particular rhythm, our fear is that it might progress to a third-degree AV block. And therefore, what's going to be an intervention that is going to be appropriate for this kind of rhythm is to have the patient scheduled or brought to the cardiac cath for an insertion of a transvenous pacemaker. Okay. Oh. There you go. Could you please indicate in the chat what your answer is? Okay, most of you were able to get torsades de point. What is torsades de point? Torsades de point is a specific form of what is known as a polymorphic ventricular tachycardia. And this usually is found in patients with long QT interval. So what is the characteristic of a torsades de point? Well, torsades de point is a French phrase which literally means of different heights or of different points. Of different heights or of different points. So as you could see in this particular example, you notice that there is, in fact, a tachycardia, a fast rhythm. And if you look at the points right over here, you're going to see once again that there is a variability. Sorry about that. Of the points that are going to be seen right here. So let me just, okay. So if you take a look at the points right over here, it is twisted and it looks like a party streamer actually. Okay. So this is the hallmark of torsades de pointe. Torsades de pointe is a polymorphic ventricular tachycardia. This arrhythmia may cease spontaneously or actually could even degenerate into ventricular fibrillation. So therefore, it causes significant hemodynamic compromise and often death. So how do we diagnose torsades de pointe? Obviously, it is diagnosed by electrocardiogram, and it may cease spontaneously, as I said, or it could degenerate into ventricular fibrillation. The treatment is with IV magnesium and measures to shorten the QT interval. If the patient becomes unconscious in torsades de pointe, the patient therefore must be defibrillated. So that's the intervention of a patient with torsades de pointe. Okay, what is your diagnosis? All right, some are saying ventricular tachycardia, very good. And the others? Monomorphic ventricular SVT. Okay, so some people are saying SVT, some people are saying ventricular tachycardia. So let's take a look at this one. So let me just tell you that this was taken from a child of 9 years of age. And so this is a very interesting case because it tells us about the presence of some abnormality. And I will tell you about that abnormality. Okay. So let me just do this. Okay. So if this is the AV, let me just change the, if this were the AV node, and we know that these are the bundle branches that go down the right and the left, right? Usually impulses come from the atria, traverses the AV node, and goes through the bundle branches, the right and the left side. This is the normal pattern of electrical impulses traveling into the ventricles. Now, there is a situation, however, wherein an individual might have a congenital defect. And this congenital defect is going to have an accessory pathway. Accessory means to say an extra road, so to speak, that bypasses the AV node. So let's say now that there is a route over here that goes to the ventricles, and they do not, therefore, allow for impulses to travel the normal route through the AV node. If an impulse does not travel to the AV node, does it move faster or slower? If an impulse does not travel through the AV node, does the impulse travel faster or slower? Faster, because the AV node usually slows down conduction, isn't it? So this is a very common finding in patients who have an accessory pathway. And the presence of an accessory pathway, therefore, is number one, characterized by a shortened PR interval and a presence of an abnormality in the QRS complex. So what do I mean by that? Usually when we have a QRS complex, there's a smooth upward stroke and a downward stroke. And this results in a normal and narrow QRS complex. However, in individuals with an accessory pathway, what's going to happen is you're going to have an initial slurring of the QRS complex before it goes up. So notice this slurring right here. This slurring is what we call a delta wave. Okay? And this actually is the characteristic of a condition known as Wolff-Parkinson-White syndrome, or WPW. Wolff-Parkinson-White syndrome. These are the three cardiologies that actually recognize and describe this in literature. And the presence of the delta wave and a shortened PR interval are the characteristics of a Wolff-Parkinson-White syndrome. So again, WPW is characterized by the presence of an accessory pathway or a bypass tract. This connects the electrical system of the atria directly to the ventricles, allowing conduction to avoid passing through the AV node. Now, in normal individuals, when the sinus node creates an action potential, it must pass through the AV node to get to the ventricles. When there is an accessory pathway, the sinus node action potential can pass through the bypass tract before the AV node, resulting in the ventricles becoming rapidly depolarized. This term is what is known as pre-excitation and results in that shortened PR interval on the ECG, as well as a delta wave. So again, what is the delta wave? A delta wave is the slurring of the upstroke of the QRS complex. And this occurs because the action potential from the SA node is able to conduct to the ventricles very quickly through the accessory pathway. And thus the QRS occurs with a delta wave. So let's find out if there's a delta wave over here. Now, I'm now going to clear all my drawings, exit, and I'm now going to zoom in. Okay. Do you identify a delta wave in these ECG? So notice this initial upstroke over here. This is the leg of the delta wave. You might not be able to see what I was trying to point out, but this is the delta wave right here. You notice that? That is the delta wave, and therefore is going to be suggestive of the presence of WPW. All right, are there any questions as far as this is concerned? No questions? Okay, let's go to the next one. Okay, could you please put in the chat what your diagnosis is? Okay, so the major observation that you have noticed is the inverted P waves, correct? And we said that inverted P waves originate from the AV node, and we therefore call them junctional something. The rate over here is 69. And so there is a rate-related nomenclature as far as impulses that come from the AV node. So if the rate is between 40 to 60, we call this junctional rhythm. If the rate is between 60 to 100, then we call this an accelerated junctional rhythm. And as you could see, what is the rate over here? We have a rate of 69, and therefore we would call this an accelerated junctional rhythm. If the rate were over 100, then we would call this a junctional tachycardia. Okay, so this is a junctional, accelerated junctional rhythm. So what's the implication of an accelerated junctional rhythm? Well, this usually are manifestations. Any beats that come from the AV node are usually manifestations of an abnormality in the AV node. But a lot of times it's a reflection of drug effects, in particular digitalis. Not actually toxicity, or not necessarily toxicity, but only a drug effect. Okay, so any drug that exerts the effect on the AV node may cause junctional rhythms. Okay, so let's move on. And it says that we have to have a break. So let's go ahead and have a 5-minute break. If you have or should have any questions, please make sure that you put them on the chat box right now. Thank you so much. So let's go ahead and have a 5-minute break. Okay, welcome back to the second half of this presentation. And before we go further, There was a question, or there were questions on repeating the items on WPW, which I will be glad to do. Okay, so let's go ahead and let's see if I could do this. Yes. All right. So what I'd like to do now is to talk a little bit about what WPW is, or an accessory pathway. So in a normal transmission of electrical impulses, the sinus node fires and it travels to the atria, and the impulse is usually delayed in the AV node. And from the AV node, it travels to the bundle of His, and from the bundle of His, it travels into the bundle branches and on to the Purkinje fibers. This results in a normal conduction of atrial impulses into the ventricles, and therefore you have a normal PR interval and a normal QRS complex. So let's see now what happens when you have an accessory pathway. So if this were the AV node and these were the bundle branches, accessory pathways are abnormal channels or abnormal roads, so to speak, that bypasses the AV node. So there's an abnormal connection between the atria and the ventricles. And when this happens, therefore, an impulse can travel from the sinus node onto the atria and right over here. And if you bypass the AV node, then you would have a shortened PR interval. In addition to that, because now it traveled to this route, it didn't go into the AV node, causing simultaneous depolarization of the ventricles. It's going to be manifest with a short PR interval and a delta wave. And the delta wave is an initial rapid, obscure sign or inscription into the QRS complex. That is the delta wave. So there's an initial slurring of the first part of the QRS complex. So that is WPW. It stands to reason that when patients present with tachycardia, one of the suspicions that we have in the emergency room is that the patient may have what is known as an accessory pathway, or WPW. And therefore, this is a very important consideration, because a frequent cause of tachycardia is going to be the presence of an accessory pathway. So how do we usually treat this? Well, the way in which we treat this is to ablate the accessory pathway. Ablation means to say we're going to burn this through a laser, so that if you burn this, it becomes a scar tissue and it will no longer be able to transmit electrical impulses into the ventricles. Okay, so that is WPW. Did that answer your question, questions, Joselito as well as Cecilia? Yes, you're welcome. Thank you very much. All right. And the other question was, does the delta wave only appear in lead 2? Actually, it would appear in any lead, okay? But most significantly, actually in the V leads would be where you would identify this particular beats, okay? Okay, so let's move on. This is a tachycardia of some sort, isn't it? The rhythm or the rate is fast. And there are times wherein the rhythm is going to be confusing. So how many of you, let's have a vote. How many of you think that this is ventricular tachycardia? Hello? How many of you think this is ventricular tachycardia? All right, good, good, good. All right. Thank you. How many think this is supraventricular tachycardia? Okay, so some of you think that this might be a ventricular tachycardia, and the reason why you're saying it's a ventricular tachycardia, it is a wide QRS complex. But some of you are also thinking that this is a supraventricular tachycardia that is aberrantly conducted. So let's talk a little bit about the concept of aberrantly or aberration. Okay, so when we say that something is aberrantly conducted, what are we talking about? So aberrancy in aberrantly conducted means this thing. Let me just, okay. So again, here is the bundle branch, the AV node, and the AV node will now have a connection to the bundle of His, and from the bundle of His on to the right bundle, as well as into the left bundle. Now, there are some situations wherein we know that there is going to be a blockage in the bundle or right over here on the other side. And this blockage, therefore, will result in an abnormal conduction into the ventricle. So it would go this way without the impulse going to the other side. Aberrant means to say abnormal. So the conduction to the ventricles is going to be abnormal. That is what is aberration, or what is known as aberrantly conducted beats. Okay, oops. All right, so going back to this one, there is a possibility that this is a ventricular tachycardia or a supraventricular tachycardia with aberrant conduction. Can you actually differentiate between these two? And the answer to that is yes. But it can be very difficult, and even experienced clinicians can misdiagnose ventricular tachycardia as supraventricular tachycardia or vice versa. And therefore, this could lead to clinical misadventure. Now, what is the problem here? The problem is treating a wide complex tachycardia, for example, with a calcium channel blocker, is a dangerous decision that can have fatal consequences for your patient. Thank God there is a good criteria to rule in or tip the scales in favor of ventricular tachycardia. And so whenever you see a wide complex tachycardia, always make sure to do a 12-lead ECG. Why do we want to do a 12-lead ECG? Now, the reason why we want to know to do a 12-lead ECG is because of the fact that it tells us whether or not what we're seeing is actually ventricular tachycardia, or it is simply a supraventricular tachycardia with aberration. So there is what is known as a Brugada criteria that will help us determine whether or not a tachycardia is ventricular tachycardia or supraventricular tachycardia with aberration. So the first criteria is to look at all the V leads. And if you look at all the V leads, so from V1, from V1 to V6, these are all the V leads. Are all the complexes going in the same direction? Are all the complexes going in the same direction? No. Okay. If the V leads are all concordant, meaning to say that they are going in the same direction, the rhythm is ventricular tachycardia. Does everybody understand that? So whenever you have a fast rhythm and you're thinking, well, it could be a SVT, but it could also be an SVT with a ventricular tachycardia, then the answer should be, or to arrive at the answer, you must do a 12-lead ECG. If the 12-lead ECG shows concordance in the V leads, which means to say that the directions in the V leads are all the same, then the answer is going to be ventricular tachycardia. So in here, in this particular example that we have, this is not ventricular tachycardia. This is a supraventricular tachycardia resulting from a wide QRS complex because of the presence of a right bundle branch block. Okay? Are there any questions regarding this particular strip? Questions? I'm not seeing your chat. Okay. Any questions? Should I move on? Thank you so much. All right. Okay. So recap. If you have a wide complex tachycardia, don't assume that it's ventricular tachycardia right away. Right? What do you have to do? We have learned today that when you have a wide complex tachycardia, you must do a 12-lead ECG. Why do we want to do a 12-lead ECG? We want to see the V leads if there's concordance. Concordance means to say that all the waveforms are going at the same direction. If they're going at the same direction, then that means to say that this is ventricular tachycardia. In this particular example, we know then that this is not ventricular tachycardia. This is SVT with a aberrantly conducted SVT. All right. Senorita, you probably have to reboot or log out and then log back in if you can't hear me clearly. It would be from your end, okay? Does anybody have any problem hearing me? Anybody else have problems hearing me? Okay, so it's your connection, Senorita. So just go ahead and please check your connection. Sometimes logging off and logging back in may help. We can't relay in cardiac monitor to assume the differences with VTAC and SVT. Correct. Prim, whenever you have a patient in tachycardia like this, it's always our routine here in the United States that we obtain a 12-lead ECG. Okay? This is so that we recognize that there is a possibility that there's going to be instances wherein we have a tachycardia that might be wide, and there are two possibilities: ventricular tachycardia, and the other one is SVT with aberration. All right, so let me just clear all my drawings, and I'm going to exit. Okay. Would you please type your answers on the chat, in the chat box? Okay, the answer to this is obviously it is a flat line with basically just P waves present, and therefore we appropriately call this a ventricular standstill. So the treatment for ventricular standstill, or the interventions, I should say, is first of all, make sure that it is actually the patient and not just a disconnected lead, right? Because if you disconnect an electrode, it might mimic this particular rhythm. So we always have to assess the patient. If it is the patient, in fact, and we have established by checking all the leads, we're going to therefore perform CPR. And what is the other intervention for ventricular standstill other than CPR? Epinephrine. And those are the only two interventions known to man for this particular rhythm at this point. Okay? All right, let's go to the next one. Okay, so everyone had said that this is atrial fibrillation. So I guess everybody is aware of what atrial fibrillation is. But just as a review, I wanted to tell you what the characteristics are for atrial fib. And the first one is that it is an irregularly irregular rhythm. That is the first criteria for atrial fibrillation, and non-identifiable P waves. That's the second criteria for atrial fibrillation. So whenever we recognize atrial fibrillation, there's also going to be a characteristic wavy baseline. So you see in this particular example that there is a wavy baseline, and therefore, having met all these three criteria, we could conclude that this particular rhythm is in fact atrial fibrillation. So what are the interventions for atrial fibrillation? Well, new onset atrial fibrillation must always be reported to the healthcare provider because of the risk of formation of embolic phenomenon. One of the major complications of atrial fib is actually a CVA. In fact, 97% of embolic strokes are caused by atrial fibrillation. And therefore, when atrial fibrillation is going to be noticed, there are two goals of anybody that is treating them. And the first one is to regularize the rhythm to normal sinus rhythm. And secondly, to prevent emboli formation. And therefore, these patients can either be prescribed calcium channel blockers or digitalis, and in addition to that, anticoagulants in order to prevent embolic phenomena. Please indicate your responses or answers in the chat. There's only one response so far. Okay, very good. More. Excellent, excellent. All right, one of the most significant findings that we see in this particular strip is the presence of spikes. And this is an example of a spike that we see. These are the spikes. This is a spike. This is a spike right here, and a spike, and so on. Okay. So these are artificial marks caused by the discharge of an impulse from an artificial pacemaker. So these spikes are what we call pacing spikes. So when looking at these beats, we characterize these beats because they're caused by the pacemaker as a pace beat. So we would call this a pace beat. But there's also another kind of beat that we notice over here. And this is this particular beat right over here. This is what is known as a native beat or a natural beat. Inherent, native, or natural beat. It is going to be a normal pattern, and therefore it's going to be important to identify it because we know that the patient is not 100% relying on the pacemaker. In addition to that, though, we have a very significant finding. And that significant finding is the presence of a spike right over here. There's a spike right over here that is not accompanied by anything at all. This is significant. So the correct answer here is there is a ventricular pacemaker that has evidence of loss of capture. Loss of capture means to say that the electrical impulse that was discharged by the pacemaker was not sufficient enough to cause a response by the ventricles. And therefore, there is a pacing spike without the QRS complex. So this is what's called a ventricular pacemaker with loss of capture. Loss of capture because an impulse was created as evidenced by this spike right here, but there was no response whatsoever. And therefore, the correct answer is letter C, ventricular pacemaker with loss of capture. So what's the implication here? The implication is a lot of times it is because of a decline in the battery power, and therefore we need to make sure that we check on the battery. The other thing is that sometimes what happens is that there's going to be an intermittent failure of capture. And the reason for that is because of the situation we're in. I'm going to illustrate it. So supposing now that this is the pacemaker lead, and sometimes with the pacemaker being with the patient for a long time, scar tissue might cover this particular electrode. And if you cover that electrode with scar tissue, therefore, electricity will not be able to come out of that electrode in a normal fashion. And therefore, it will cause intermittent loss of capture. Okay. Oh. Okay, so let's discuss this. Again, we have P waves without QRS complexes, and therefore we would say that there is an AV block, right? And in determining what kind of AV block there is, we're going to, again, have to measure the PR intervals. So let's measure the PR intervals. And as you could see right over here, this is the first PR interval. Oops. Okay, and the second PR interval is not the same. And the third PR interval is short again, so it's not the same. So whenever we have a variable PR interval, this is going to be called a third degree AV block. The correct answer is a third degree AV block. Okay. All right. Kindly indicate your responses on the chat box. Okay, so you have identified that there is an AV block, and the reason why we say that there is an AV block is because of the fact that there are P waves without QRS complexes. So now we're going to look at the pattern of the PR interval. So here's the first PR interval. And here's the second PR interval. It is longer. And then it repeats itself again As you could see, there is a short PR interval here, a longer PR interval, and then there's going to be a non-conducted P wave. So this is the characteristic of a second-degree AV block Mobitz 1, or a type 1 AV block, also known as AV Wenckebach. So how do we diagnose a second-degree AV block or type 1? And these are the characteristics of how you could identify an AV Wenckebach or type 1 second-degree AV block. The first one is that there's gradual prolongation of the PR interval, as illustrated here. And whenever you see groupings like this, so look at this, 2 over here and 2 over here and another 2 over here perhaps, this is going to be characteristic of a Mobitz type 1 or AV Wenckebach. So gradual prolongation of the PR interval and group beats are characteristics of a second-degree AV block type 1. Now, what's the implication of a second-degree AV block type 1? Is this serious? Well, usually this is something that we are not going to wake up the doctor for. It is a benign rhythm, and usually it's associated with myocardial infarction, but usually it's just the inflammatory changes or the inflammation that causes this particular type of block. So it does not require pacemaker insertion or any drug therapy, unless, of course, the patient becomes symptomatic, which is unlikely to happen. Okay? So we have come to the conclusion of this particular part of the presentation, because what I want to do now is to go to Kahoot to play a game so that we can, assess our understanding of the presentation. So before I go to Kahoot, are there any questions that you might have before we go to our quiz? Okay, if you don't have any questions, what I'd like to do is to ask you now to either take out your phone or open up a new tab on your computer and go to kahoot.it. I will share the screen in a little bit. Let me do that now. And we're going to, yeah, it's coming. All right, please go to kahoot.it, not .com.it, and enter this in numbers. All right, and the object of the game is actually to answer as quickly as possible. All right, so whoever answers the quickest is going to be the winner. And this is just a good way for us to assess what we have learned. All right, we're waiting for the others. If you're using a laptop, you can go ahead and open up a new tab and go to kahoot.it. All right. Okay. So we have 19 people that are ready to play. For the others, you could actually join again once you are able to log into kahoot.it and type in the PIN number as shown above. It will also be shown on all the slides. All right, so in the interest of time, let's go ahead and get started. For those who are able to join, let's go ahead and begin. Okay, the correct interpretation is a ventricular pace beat. So let's go ahead and determine why that is. And so if you're looking at this ECG, the most significant finding that you will see is actually the presence of spikes, okay? And this means to say that there's a ventricular pacemaker. And the reason why we say that there's a ventricular pacemaker is because of the fact that the spike is followed by a QRS complex. Okay, so let's see who answered the fastest. And the winner for this particular question is Clint, Kisinga, Jack, Marian, and Lito. Congratulations. All right, and the correct interpretation of this particular strip is that there is a third-degree AV block. As we could see, there are variable PR intervals, which are the manifestation or the characteristic of a third-degree AV block. Okay, so let's see who actually won this particular part of the game. And again, Clint, Kisinga, Lito, Angelique, and Riza. Let's go to the next. Okay, so this is sinus rhythm with bundle branch block. And the reason why it is bundle branch block is because we see a normal pattern for all the waveforms except for the QRS complex. The QRS complex is wide, as you could see, and there's slurring of the QRS in itself. So this is a manifestation of a bundle branch block occurring. So let's see. Again, Angelique is now the fastest, with Clint, Kisinga, Lito, and Abby being also runners-up, and Dimp is the highest climber, which means to say it's got the best improvement. Okay, so we see an even baseline, and we cannot identify any complexes at all. This is a characteristic of ventricular fibrillation. There are two types of ventricular fibrillation, one that is going to be coarse, and the other one is going to be fine. This is a fine ventricular fibrillation. And so let's see who won. Clint came back, Kisinga, Angelique, April, and Lito. Okay, so the correct interpretation of this rhythm is that it's a second-degree AV block type 1. Why type 1? Well, if we take a look at it, there is a gradual prolongation of the PR interval, and the second characteristic are the group beats. Remember what the group beats are, as I illustrated earlier. As you could see, there are two that's group over here, another two that's group, and maybe another two that's grouped right over here. So this is a clear indication that there is a second-degree AV block type 1. Okay, and so let's see who won that particular game. Kisinga, Clint, Angelique, Eileen, and Marcia, and Marian, congratulations, we are the highest climber. Okay, some of you said that it was sinus tachycardia. The rate is 190 or 180. So it's beyond the mark of a sinus tachycardia. This is a SVT or supraventricular tachycardia. The other name for supraventricular tachycardia is paroxysmal atrial tachycardia, or also narrow complex tachycardia. All right, so let's see who was the fastest over here to answer. And let's see, Kisinga, Clint, Angelique, Abby, and Jack. And we need to recognize Chang, who is the highest climber right now. Okay, so again, in this particular rhythm, there is a different heights or different points. So I'm going to illustrate the different heights and different, see this? And this. So it's almost like a party streamer. It has different heights or different points. And therefore, this is going to be what is known as torsades de point. So let's see. Kisinga, Clint, Angelique, Abby, and Jack, and Dimp is the highest climber. Congratulations. Okay, the correct answer is that there is a sinus arrest. So why sinus arrest? Let's take a look why it is sinus arrest. My caliper is not coming. Okay, so the problem is that we have a pause right over here. Let me just annotate, draw. Okay, so we have a pause right over here, and there's a clear reset after the pause. This was the rate before the pause, and that's the rate after the pause. And therefore, this is what is known as a sinus arrest. Okay? And yeah, a lot of you said that this was a non-conducted PAC. So again, in a non-conducted PAC, you would have a P wave without a QRS complex. But there's no P wave that is premature that doesn't have a QRS complex. And therefore, this is a sinus arrest. Okay? So let's see. Kisinga, Clint, Angelique, Eileen, and Abby were all the fastest. Okay, so what is weird or what is unusual about this particular strip? Well, the one that is unusual about this particular strip is the fact that we have different configurations of P waves. So we have an inverted P wave right there, upright P wave, and then a flat P wave right over here, and even another flatter one and inverted here. So there are 3 or more configurations of the P wave. This is a manifestation, therefore, that the pacemaker is wandering. And therefore, this is aptly called a wandering atrial pacemaker. Okay, so let's see who answered that correctly and fastest. Clint, Kisinga, Lito, Angelique, Jack, and Cheng again is the highest climber. And the last one. Okay, so the correct answer is that this is a ventricular pacemaker with loss of sensing. Let's discuss why this is a ventricular pacemaker and why there is loss of sensing. So first, we're going to look at the spikes right over here and the spikes right over here causing a QRS. So therefore, this is a ventricular pacemaker. Then we take a look at the other beats. This is a natural beat or an inherent beat, a natural beat. And there is a pacemaker spike right over here. This is inappropriate because there is a natural beat right over here. We don't need a pacing activity right after a natural beat. The problem here is that there is loss of sensing. The pacemaker did not detect this QRS complex, and therefore it activated the pacemaker prematurely and abnormally. This is termed a loss of sensing. Okay, so let's take a look at how you did in this particular question. And we see that in third place is Eileen. Clint is in second place. And the first place goes to Lucinda. Congratulations. Okay, so now we have come to the end of our presentation. I want to thank you again for your participation in this webinar, and I hope to see you in future webinars. I will remain online for the next 20 minutes to answer any questions that you may have. It has been my pleasure to present this webinar, and I hope that you were able to learn something regarding complex arrhythmias. I will be sending you the link to the survey. Actually, I'm going to copy that now, and I'm going to put that in the chat box so that you could go ahead and fill out the evaluation form. Thank you very much, and I look forward to seeing you again. Thank you. Thank you.